Hello, and welcome to Informed in 30, a new series from the National Brain Tumor Society designed to give you, our patients and caregivers, everything you need to know about cutting-edge advancements in brain tumor research and treatment. Our topic today is innovations in neurosurgical techniques. My name is Rachael Kittleson, and I'm the Director of Community Relations here at the National Brain Tumor Society, and I oversee our Connections program, which provides support and assistance to individual patients while advancing connection and care for the entire brain tumor community. I also represent the community as a former caregiver to my daughter, who passed away from glioblastoma in 2017. Joining us today is Dr. Kirk Tanner, National Brain Tumor Society's Chief Scientific Officer, and Dr. Edjah Nduom, Associate Professor in the Department of Neurosurgery at Emory University School of Medicine. Thank you both for joining us today.
Thanks, Rachel. I'm really happy to be a part of this series, being able to bring such important information to our brain tumor community. And it's also really great to have such a fantastic partner today in Dr. Nduom, who is also a valued and strong contributing board member of NBTS.
Yeah, well, it's a pleasure to be a part of NBTS and to be able to serve and to participate in the program today. I'm really excited to share my thoughts on how neurosurgery is getting even better for brain tumor patients today.
Thank you very much. So, why don't we get started with an overview of neurosurgical techniques and what that means to patients. And Dr. Nduom, as an emerging leader in the field of neurosurgical innovation and patient care, we're so fortunate that you can be able to be with us and give us an overview of the landscape and also maybe share some key items of advice in highlighting cutting-edge surgical technology in brain tumor clinical care. So with that, I'll turn it over to you, Dr. Nduom, for the presentation.
Okay, great. So we'll just get our slides up here. So again, Edjah Nduom, Associate Professor of Neurosurgery here at Emory, was recently at NIH and just made it back down to Atlanta where I trained, and really excited to be able to treat the patients around here. And I'm going to share with you some things that that we do to take care of our patients here at Emory, and things I've done at other centers that will hopefully answer some of the questions, remove some of the anxiety around surgical techniques that we use. So just as an outline, first we'll just give a little bit of background on what we're talking about here. One thing, I'd like to jump straight to the techniques, but I think it's important to spend some time talking about who should be doing surgery on brain tumors and why we do this surgery. And then I can focus a little bit more on how we actually do surgery to make sure that it's as safe and effective as it can be for patients and their families. So reasons for surgery. In general, when we have a brain tumor patient who presents to us, we have something on imaging, we don't know that it's a brain tumor until we actually have a piece of it. That's the thing I tell all patients is we never know 100% what we're dealing with until we've actually taken a piece of it. And that means surgery of some form. For things that are benign, like a meningioma, most meningiomas, we do surgery to cure the disease. Take the lesion out, make it not a problem anymore. For others that can't be cured with surgery, surgery can still be a critical part of someone's survival by safely reducing the amount of disease, trying to go from 1 million brain tumor cells to 100 or 1,000 so that the radiation and chemotherapy can be more effective. And sometimes for clinical trials, in some small trials, surgery actually helps us improve ongoing trials and understand how things are working. So the initial management, kind of when to do surgery. Surgery turns out is very rarely a true emergency when you're talking about brain tumors. Sometimes with very rapid patient decline, they're not talking, they're not able to protect their airway or speak, or there's a big bleed, that's the hemorrhage that's associated with it, then we may say, we need to rush this patient urgently, emergently for surgery. Most times we can give Decadron, it's a steroid for symptomatic lesions or seizure management. And at that time, I'm actually on call today, and someone might call me and say, hey, we're at a community hospital. We have a patient that looks like they have a brain tumor. Can we send them to you for management? We might do surgery in the next few days after that. So who should operate on brain tumors? Neurosurgery has changed quite a bit over the last several decades, and most people, when they think neurosurgeon, think someone who takes out brain tumors. But quite frankly, most neurosurgeons actually spend most of their time operating on spine lesions, not tumors, but just people that have degenerative spine disease. And so tumor is very subspecialized. There are things within the tumor field even that I don't typically do because there are people that specialize just on that type of tumor. So there are spine surgeons, vascular surgeons who do aneurysms and that sort of thing, spine surgeons who are particularly into scoliosis. So it really is important to know that you can look for a surgeon who has decided to seek board certification in a subspecialty like tumor. So, I really can't emphasize this enough. When patients are, confronted with something that needs surgery, I think it's a very fair thing to ask the neurosurgeon involved whether they actually focus on brain tumors and that's something that they do in their day-to-day practice. So, one of the things that we're doing, Emory has a fellowship that is training more specialized neurosurgeons just to do tumors. There are fellowships across the country that are doing the same. And I do think it's important that we continue to establish centers of excellence where everybody in a region knows, hey, this is the place I should go to if I'm faced with a brain tumor and I need surgery. So, okay, talked a little bit about that. That's one of my soapboxes. I'm off my soapbox now. So how do we do this? How do we take tumors out? So this is a picture of a resection that I did. And just to show, how do we do a surgery like this safely? And this is actually a patient that, quite honestly, was back at his desk working in 2 weeks after surgery. So we use a lot of different, what we call surgical adjuncts or tools to help us make surgery safe. And it'd be impossible to go through an exhaustive list of all the things that we do, but I'm going to run through some of the things that we routinely use that I think make surgery safe and effective as we go for what I like to call a maximal safe resection, which is taking out as much of the tumor as we can while balancing the patient's performance, making sure that we're not compromising their neurological status. One of them, very basic, practically every neurosurgeon who's doing any type of brain tumor surgery will have this, is something called stereotactic neuronavigation. I like to define it as the GPS for the brain. Lots of different ways to do it, different companies, but the general idea is that we map the patient's skull and their skin in the field of this infrared camera, which is looking at a point on a stick that we kind of tell it, where it is in space. And so it knows where the head is in space, it knows where the pointer is in space. And once it figures that out, it then gives us a map using the patient's own imaging where I can tell where I am on a patient's MRI at any given time. Know where to make my incision, know where the lesion stops and starts. Very useful. Neuromonitoring is something that typically most specialists would use. Not every neurosurgeon might consider neuromonitoring. I do, and the general idea is we try and find out in surgery where the functional parts of the brain are so we can avoid them and leave them intact. Cortical versus subcortical is just surface of the brain, mapping that and figuring out which fold of the brain I'm dealing with. This is one that's involved with speech or motor. Subcortical is the same idea, but now I'm looking at the white matter connections connecting different parts of the brain. So patient selection for this. So this is a patient that had a recurrent glioblastoma that was just behind the motor strip that we could tell based on location on the imaging plus their function. And so in surgery, this is a picture of in surgery using a subcortical probe, monopolar probe, to see if we are now in the white matter descending from that motor cortex. And using that, we're able to do a resection where we take out the bulk of the lesion and only leave the part behind where there is a functional tissue and we get some motor stimulation. Moving along, this is another one of my own cases with the same thing. The images are actually going from right to left, pre-surgery to post, where this was a lesion that initially some thought might not be resectable because it looked like it was directly in the motor strip, but using mapping, we were actually able to tease the lesion out itself and leave the rest of the brain intact, allowing the patient to leave the hospital without even needing rehab. Another thing that I like to use, sounds very basic, is intraoperative ultrasound. Intraoperative ultrasound is where we literally use an ultrasound probe, just like you would in pregnancy, for example, and see where the lesion is in real time. So on the right is the ultrasound image that corresponds with the MRI you see on the left. And that is something we use that's very helpful to make sure that we don't have any residual when we're taking lesions out. We also use diffusion tensor imaging, DTI, fiber tracking, which can give us an idea of where those white matter pathways are before we even get into surgery, so we can kind of know what might be safe to approach. And at some centers, they even use an intraoperative MRI. And using that intraoperative MRI, they will actually do a new MRI in surgery and see what might be left. This is just a picture of me operating the MRI coil back when I was at the NIH. This is another patient I took for surgery at the NIH, positioned for going into the MRI coil. And this is an example of a case where, I take out what seems like as much of the lesion as I could, and then do an MRI and find that there might be some residual. And by the end of surgery, we're able to take out the entire lesion. Here's another one. You can see on the far left is what the lesion first looked like. In the middle is what the MRI looked like during surgery, where I could still see there was a little bit more lesion that needed to be resected. And then on the far right, where the lesion has been completely resected. Now, honestly, I have replaced intraoperative MRI with ultrasound in my practice, and I'm able to get the exact same results with that. But some people will still choose to use an MRI in surgery. And then there's awake craniotomies. People may have seen the videos of people playing the guitar or singing in the operating room to make sure that they can still keep that function after surgery. I typically will do awake craniotomies mostly for lesions that are near speech. So this is such a lesion in the left frontal lobe where I was worried that it might be in a functional speech area. And so I went ahead and did this case awake, and I'm able to map out the functional area and stay away from it and not cause any problems. This is one case where I used several different adjuncts. This was a patient that came in with a lot of speech problems because they had this lesion here in the left panel. On the right is after we had taken it out. And again, very worried about the patient's speech. And so I first mapped the patient's cortex while they were awake. And then I actually proceeded with that surgery using something called 5-ALA. 5-ALA is a compound that patients take by mouth. It's metabolized in the body, and then it actually accumulates in tumor cells. And when we shine a special blue light on them, it glows pink. And so you can see here, it'll show me where there are infiltrating tumor cells. And so after taking the bulk lesion out, which is kind of this bigger part here, it can still show me when there are still some remnants there. So while with this patient still awake, I use the fluorescence to see where there are infiltrating cells, continue to have the patient talk to us and make sure they're still okay. So again, I can get that maximal safe surgery. And there are some centers where they use something called fluorescein for the same purpose. Got a few more slides here. Just a couple other adjuncts that we use. One is an endoscope, which is a long cylindrical camera that we can insert into the fluid-filled spaces of the brain specifically most of the time, and in some other areas to get a really good view up close to something. This is a case that I was doing. It's a little video of what it looks like inside the fluid-filled spaces of a patient's brain where I was doing a biopsy of a lesion safely through a tiny little incision. There's also something called tubular retractors. BrainPath is one such company that creates these, where you can drop a tube through the folds of the brain all the way down to a deep lesion, and in some ways more effectively take out a deeper lesion when it would have been much more destructive to try and go open through the brain using a big microscope. Speaking of microscopes, we use very complex operating microscopes that allow us to get great visualization and illumination of the field. But there are also these wonderful things called exoscopes now, where there's just an arm that you put on top of the field, and it gives you a brilliant image, sometimes even in 3D outside the body. It's more ergonomically satisfying for the surgeon, and sometimes can help everybody else to see the case better. Finally, a couple things that are surgery, but surgically related, but are treatments. One is a gamma-tile therapy, which is a type of brachytherapy. It's a way of actually placing these wafers that have radiation in them to apply radiation directly to the field immediately after surgery. My colleague, Dr. Huang, who provided this slide for me, has been doing that for several cases and is running a trial for that here at Emory. And then there are things like laser interstitial thermal therapy. I used to say patients would ask, oh, do you treat things with lasers? And I'd say, well, not really. But it turns out we do. And again, my colleague, Dr. Huang, is one of the experts on this. And you can place these little catheters in and kind of burn a lesion away. The last thing I'll say is wrapping up, is that surgery is not enough. So even in cases which I would consider to be very technically well done cases where I'm able to take a lesion out like this from the insular cortex, When we're looking at some problems like glioblastoma, where surgery is not a cure, even with the most technically advanced things where I use my stealth neuronavigation as I'm doing now to find the lesion, and use my small bipolars to get around a very vascular lesion and make sure that the vessels aren't causing problems, and are able to go down and debulk it further. We have a thing called an ultrasonic aspirator, which helps us break up the lesion even more and suck it out safely. But even in this case, which this case took me probably about 5-6 hours of time, these lesions are still infiltrated. And so even when I think that surgery has gone as well as it can go, the patient's out of the hospital and not having any problems and doing well, they're still going to face challenges, and that's why we need to continue to innovate, continue to push the field forward, and make sure that the patients have good outcomes beyond even that immediate postoperative period. Just for this case, I'll just say right now there I'm stimulating to make sure that there is no motor function deep to the lesion. And once I'm sure that that's safe, this is that ultrasonic aspirator that I was talking about, cleaning up those last few cells. We clean up everything afterwards, and you can see on the MRI that the lesion is well resected. So as I was talking about, with lesions like this, unfortunately, even though we take out the bulk of the lesion, beyond what looks like the bulk, there are these infiltrating cells that we need to take out. Last thing I'll say is we sometimes do surgery for our clinical trials. This is a clinical trial I was running at the NIH, and I'll be running at Emory soon. We use these small microdialysis catheters to actually measure the immune response of a drug in patients. And with that, I will finally give it a rest and get back to this discussion with Kirk, and hopefully answer some of your questions as well.
I'm kind of bummed that we have to stop, because that was such a great overview in a short amount of time, really powerful, and hopefully we can kind of follow up on a lot of these in the future. So thank you very much, Dr. Nduom, for that amazing overview. Surgery is clearly such a fundamental component of a brain tumor patient's care and treatment journey. Mm-hmm. And it's also really, as I learn more, it's becoming clear that these neurosurgical detection and therapeutic treatment strategies are really at the forefront of innovation. National Brain Tumor Society's Defeat Brain Tumors funding platform, and also our Venture Philanthropy Investment Fund, takes this into account. And we're trying to work to incorporate a strong neurosurgical strategy component into all of our projects whenever possible. So with that, I'll now hand it back over to Rachael for some questions for Dr. Nduom.
Kirk, thank you so much for that. And honestly, Dr. Nduom, thank you so much for that presentation. It truly is fantastic, and I know will be something very beneficial to our community. And with our community in mind, we did reach out to them prior to today's recording and asked them to share with us questions that they would most want to ask regarding neurosurgical techniques. And our first question asks if the type of surgical technique used can impact their eligibility for clinical trials.
So that's a really good question. By and large, the answer to that is no. There may be some things around how much of the tumor was able to be safely taken out. So there are some trials that are specifically post-surgical that may say it's only for patients that were able to have a gross total resection or near total resection and don't have much tumor burden, something like that. Some few exceptions if there is a surgery that itself is a trial. So I'm talking about that gamma tile, for example. If you were enrolled on a trial to get gamma tile, that's going to apply some radiation. So if there's another radiation trial that you're on later, you might not be eligible for that. Similarly, if there is another trial that involves implanting things or giving another wafer, having had a wafer in the past might mean that you can't have that in the future. By and large, though, mostly what they're going to be looking at is how the patient's doing, what exactly type of lesion that they have, again, what that tumor burden is, where is it located. Those are the things that tend to come into play more rather than did you have someone take it out with a microscope or use an exoscope or something like that.
So when we have patients that are newly diagnosed, and certainly that is something that we are always trying to reach and trying to get them their most vital information as they're making decisions. When they're discussing options with their care team, how can patients ensure that the latest technology, the latest techniques are what is being used during their surgery?
Another really good question. I would say I wouldn't necessarily hang up too much on the technology piece per se. For example, if you were to say, I would love to have my surgery taken out using an intraoperative MRI, there are very few centers that use them, and even the centers that use them only use them for a small percentage of their patients, maybe 5–10% of the patients that come through, in my experience from, say, MD Anderson Cancer Center, where I did my fellowship training. So with that said, the most important piece to me is making sure that you have a specialist neurosurgeon. If you have a neurosurgeon who is a member of the tumor section, who is going to meetings and talking about the research that they do on the best ways to take out brain tumors, and are talking with their colleagues and up to date on everything, well, they're going to make sure they have the best and most effective technology for their patients. So I would focus the questions really more on experience, on the training that the person received, make sure that they had specialized training. And really, and this may sound like a funny question, but their focus. Sure, you take out maybe 20 brain tumors a year, that the person might say, which sounds like a decent amount. That's a brain tumor almost every other week. But if the other 300 cases the patient does a year are back surgery and neck surgery, then that's not their focus. They're not spending most of their time thinking about it and most of their practice thinking about it. And you run the risk of them maybe not being quite as up to date on all of the techniques and ways to approach lesions like neuromonitoring and that sort of thing.
Yeah, that's super helpful. I have to say that in listening to your presentation, something that you mentioned is, I know something that's on the mind of folks when they are trying to make their decisions, and that is if they want to pursue a specialist or even a second opinion, is it safe to delay surgery?
Yeah, I mean, again, another great question. Most times, not every time, but most times you've got a day, a couple days, a week to consider options before going to surgery. Certainly, if you're out of the hospital and you had an MRI for whatever reason and are now finding out that they're concerned it's a brain tumor, you have options to go to one neurosurgeon's office or to go to another and can ask for a second opinion. But even if, throwing up, headaches, ended up in the hospital, and they've got you in the bed and they've done the MRI and they're saying, okay, well, we need to do surgery tomorrow. If you're not comfortable with the hospital that you're at and the experience of the neurosurgeon, you can certainly ask to be transferred for them to, consider a second opinion, to call somebody for advice or help, whether that's within the group that's at the hospital or at another hospital altogether. And I'll tell you, it is not infrequent. Myself, I think I have a bit of a baby face. So every once in a while, a patient will come in and they'll say, we've heard great things about you, but, are you old enough to do this? Have you been doing this before? Like what? And honestly, I don't take offense to that. I tell people I don't get my house painted without getting 2 quotes. So, if you want to consider talking to somebody else about surgery as well, I'll give them a few names in town that they can consider that I think are reasonable people. But I'll tell them, listen, I spent 2 years just studying brain tumors at MD Anderson Cancer Center. I spent 8 months during my residency training focusing on brain tumors there. I continue to do research on the field and give talks and talk to patients about the best ways to do these things. And so I definitely feel I'm qualified to do this surgery. And I think that these are all very reasonable questions to ask, and no neurosurgeon worth their salt is going to be offended by being asked if they're specializing in this type of care.
And honestly, that's very interesting because it lends somewhat to the next question, which is that, when you are a patient and you are trying to find that specialized neurosurgeon, how do you go about doing that? So it sounds to me a little bit like you can ask the care team that you're currently with, at least, for some sort of guidance. Yeah,
absolutely. One of the most gratifying things that, Kirk had mentioned, I'm part of the board of the National Brain Tumor Society, which I love having this opportunity to help so many patients, even beyond the ones that I see in clinic, navigate these things. And they printed out the key questions from the NBTS website that I helped put together. And so they were asking me, I was like, oh yes, I help make those questions. So let's run through them. So there are several, but a few critical ones I would say are simply, are you someone that focuses on tumors? Like, is your practice, a brain tumor? If it's a brain tumor, it could be a spine tumor, or a spine tumor practice predominantly. What percentage of your practice is brain tumors? Is another way to ask the same question. Did you do a fellowship in brain tumors, or did you seek out additional training? Fellowship, something you can't. But did you get training specifically to do this type of tumor? Again, other ways to do it was like, are you the person at this institution who does the vast majority of the brain tumors? And another one, and this gives you a couple different pieces of information, is there anybody else that you would recommend? If I wanted to seek a second opinion, who would you recommend that I see? Now, any tumor neurosurgeon knows the other tumor neurosurgeons in their area, so they should be able to rattle off a few other potential options. They may say why they think they're a better option than the other person. That's up to any person's particular style, but they should know that. Knowing who's on the care team is another thing. Is there a team of people at this institution that focus on brain tumors? Neuropathologist, a neuro-oncologist, radiation oncologist that focus again on brain tumors. All really important things to figure out. And it doesn't take that long to ask that chain of questions and figure out does this have a brain tumor center? Are you working with a team of people focused on this disease group? Are you specialized in this area? Did you get training for that subspecialization?
And I guess the only thing that I would add there is that, it's amazing advice. And, I think that if you don't feel like you're in that kind of center, then, National Brain Tumor Society and others can help you navigate and try to get there, because it's incredibly important that you are getting the right care. So I absolutely agree.
I can't overemphasize that enough. Thank you so much for adding that, Kirk. That's a great resource that NBTS is now providing. David has spent time getting to know many members of the tumor section, and he has my phone number as well as do the people in NBTS. So if they don't know somebody, and I don't know somebody, that can be an indication of who you're dealing with at that time.
Rachael,
if you don't mind, if I ask one more question here, I'm going.
Absolutely.
I think it seems like we've covered a lot of the questions from the community in both Dr. Nduom's talk and then these questions. But one thing that I'm really interested in is developing new therapeutics and new treatments in clinical trials. And so, could you speak to a little bit about the role of the neurosurgeon and being able to, whether it's in a, window of opportunity or target engagement, understanding about whether, how does that all factor in?
Another really great question, and another reason to seek out care where there's going to be a tumor board with different subspecialists coming together and talking about patients and how they're doing and whether they might be eligible for different clinical trials, because that's the sort of conversation that happens at Emory, that happened at the NIH, MD Anderson, places like that. So the neurosurgeon is often very intimately involved in the decisions for clinical trials in a few ways. One, there are some clinical trials for upfront patients, and Kirk mentioned this idea of a window of opportunity trial, where the idea is patient gets a drug that we think works for brain tumors before surgery, and then we do surgery afterwards, and they might continue to get the drug after that. The neurosurgeon has to be involved in the clinical trial process, because in order to enroll a patient in that, I have to know before I'm considering surgery for this patient that there's this trial there, so I can enroll them a week, 2 weeks before I have to take that lesion out at the time that lesion might come back, as often does for these malignant lesions. So that's one of the ways too. Surgeons obviously are getting the tissue and making sure they get accurate tissue if it's from a biopsy or from a resection that fully captures what this lesion is, so we get a good molecular diagnosis. So sometimes we'll do surgery to further confirm that this truly is a recurrence, or it's just treatment effect, or that this mutation we want to target is there or not. And that might affect eligibility for clinical trials as well. And there are several neurosurgeons like myself who are developing our own trials, whether those be window of opportunity trials or trials using catheters to infuse different things like viral therapy, something I didn't talk about today, but there's a technique, convection enhanced delivery, which I study in which we place these catheters into the brain and slowly infuse things so they can go beyond the tip of the catheter and sometimes deliver therapeutics directly to the brain. So I do think it's really important that neurosurgeons continue to be involved in clinical trials. It's one of the great things that Kirk mentioned that NBTS is doing, making sure that there is a neurosurgical component to a lot of clinical trials going forward.
Dr. Nduom, thank you for joining us today, for creating meaningful content for our community, and for answering their questions that helps them to better understand advances being made to improve neurosurgical techniques to provide patients with better outcomes. And Kirk, thank you so much for helping us to break down these complex concepts for our audience.
Well, of course, Rachel, it was really my pleasure. I kind of wish this was not innovation in 30, but innovation in an hour, because I feel like there was so much more we could talk about. Dr. Nduom, thanks again for your participation and such a great overview and discussion.
Yeah, well, thank you both for putting this together. And again, it's just always a pleasure to get to interface with the NBTS community and know that I'm going to have an opportunity to help so many other patients in their journey with this disease.
Thank you both. And I would like to thank our community for joining us to be informed about innovations in neurosurgical techniques and what that means for patients and caregivers. Please join us in September during Childhood Cancer Awareness Month for our next installment of Informed in 30, Innovations in Pediatric Brain Tumor Research and Treatments with Dr. Mariella Philbin from Dana-Farber Boston Children's Cancer and Blood Disorder Center. Thank you.